Safeguard and Adult Reviews, known as SARS. So, what is a Safeguard and Adults Review? A Safeguard and Adults Review, known as a SAR, is a multi-agency process that considers what lessons can be learned to improve future practice. This includes highlighting areas of best practice which are shared with partners to enable the partnerships to improve services and prevent abuse and neglect in the future. SARs are not used to apportion blame, and as such will promote a culture that values and develops professional expertise, shares responsibility, supports effective practice, strengthens accountability, and creates an effective learning system. SARs are a statutory review process which Safeguard and Adults boards must undertake when the criteria has been met. Criteria for a SAR. The Care Act 2014 provides the legislative framework for safeguarding adult reviews under Section 44. Safeguarding Adults Boards, known as SABs, must arrange for there to be a review of a case involving an adult in its area with care and support needs, whether or not the local authority has been meeting any of those needs, if there is reasonable concern about how the SAB, partner agencies, or other persons with relevant functions work together to safeguard the adult, and the adult died as a result of the abuse or neglect or suspected abuse or neglect, or the adult experienced serious abuse or neglect. The SAB may arrange a review of any other case involving an adult in the area with care and support needs where some of the criteria above are met, or where learning or good practice has been identified. This is sometimes referred to as a discretionary Safeguarding Adults review. All members of the SAB and other relevant agencies must cooperate when carrying out reviews to ensure learning is identified and applied to future cases. The purpose of holding a SAR is to 1. Establish the facts, 2. Establish what lessons can be learned from the circumstances of the case about the way in which local professionals and agencies, or any other person involved in the care of the adult, work together to safeguard and promote the welfare of adults. 3. Review the effectiveness of procedures, both multi-agencies and those of individual organisations. 4. Improve practice by acting on learning and developing best practice. 5. Highlight good practice identified in the course of the review. 6. Provide an overview report which brings together and analyses the findings of various reports from agencies in order to make recommendations for future action. It is acknowledged that all agencies will have their own internal or statutory review procedures to investigate serious incidents. This protocol is not intended to duplicate or replace these. There are a number of processes which can run parallel to SARS, such as domestic abuse-related death reviews, known as DARDs, coroner's inquest, child safeguarding practice reviews, reviews learning from lives and the death of people with learning disability and autistic people, criminal investigations, and MAPA serious case reviews. SAR referral. Any agency, professional, or individual may refer cases to the SAB. Referrals are to be made using the consideration request form, which is to be sent to the SAB area where the abuse or neglect has occurred. It is expected that the referral for SAR consideration is made with an appropriate rationale and in a timely manner. A referral does not need to be accompanied by all facts of the case. SAR referrals made by a professional should be discussed with their representative on the NSAB SAR committee prior to the referral. For adult social care and prevention, this is the service manager for safeguarding adults. The chair of the SAB and the director of adult social services will be notified of any SAR referrals made. The SAR committee members should then be notified of the referral as soon as possible and arrangements made for the referral to be considered. An extraordinary SAR committee may need to be convened. Agencies will be asked to complete an initial summary of their involvement. The chair of the SAR committee will need to consider whether the case files relevant to the case should be secured immediately to avoid undue delay before the SAR committee can be convened. The SAR referral process. There is a thorough and detailed process that happens when a SAR referral is made, which is detailed here on this slide. You can find out more information about the SAR referral process in the Newcastle Safeguarding Adult Board's SAR Policies and Procedures, which are highlighted at the end of this video. An overview of SARs undertaken here in Newcastle. There have been 4 SARs from the year 2020 to present. Firstly, Adult L, 75-year-old female with a husband who was main carer. Adult L had complex health and social care needs. She also had significant physical health concerns, which were noted to be lymphedema, osteoporosis, leaky heart valve, atrial defibrillation, asthma and alcohol dependence. Social care needs noted clutter, hoarding and self-neglect. These conditions worsened prior to her death. Adult L had several hospital admissions leading up to the time of her death. Previously, the relationship between Adult L and her husband was violent, with Adult L being the victim and her husband being the perpetrator. Adult L was supported by lots of organisations and often declined care and support. She sadly died in hospital and had COVID-19 at the time of her death. Secondly, Adult N, a 58-year-old female who had a significant history of trauma. Adult N had complex physical health concerns, including hepatitis B and C, peripheral vascular disease, and a history of seizures. Adult N also had a head injury and lived with cognitive impairment. She had an extensive history of substance use and alcohol disorders, and for most of her adult life was in treatment receiving opiate substitution therapy as part of her treatment plan. She was involved with the criminal justice system and a victim of repeated assaults and domestic abuse from multiple perpetrators. She was supported by multiple statutory and voluntary services. Thirdly, we have Adult O, which was a joint SAR and domestic homicide review, DHR, now known as Domestic Abuse-Related Death Review, DARDA. She was a 39-year-old female who repeatedly experienced violence and domestic abuse from partners. Adult O had alcohol and drug use disorders and was drinking to dependent levels at the time of her death. Adult O had also previously been assessed as having care and support needs because of physical conditions associated with a serious road traffic accident in 2011. Physical health conditions noted epilepsy, liver disease, a traumatic brain hemorrhage, and a fractured cervical spine. She was supported by multiple statutory and voluntary services. Adult O repeatedly experienced violence and abuse from male partners for the 13 years up until her death. She died from an unsurvivable brain injury. And Adult P, a discretionary SAR about a death in a house fire. The fire investigation concluded the fire was most likely caused by a dropped cigarette. Adult P had significant physical health needs affecting mobility. They had frequent falls, frailty, and severe pain. Adult P was awaiting a long-term formal care package to start in the weeks leading up to the fire. Adult P was helped with support from family members, but what was provided and sustainability was not fully explored or understood. Agencies had raised concerns about self-neglect and fire risk. There were concerns about low weight and nutrition, hygiene, cluttered home, missed appointments, and support often not being taken up. Specifically in relation to fire risk, Adult P was a smoker who smoked where they slept, on the sofa. Adult P had limited mobility and was using medication that made them drowsy, as well as emollients that were flammable. There was no agency contact in the 22 days before death, after significant concerns were raised about Adult P's health and the fire risk. An overview of key learning. There were a total of 54 actions from Adult L, N and O SARs, ranging from single agency actions to systems and policy actions. These actions predominantly cover the 3 Ps: people, policy and process. All cases involve domestic abuse, self-neglect, compromised physical health, and all with a dependency relating to drugs and/or alcohol. So the key learning of note: the need for effective utilisation of the Mental Capacity Act for those using substances and/or alcohol. The importance of effective engagement tools and skills to engage people with services. The need for alcohol screening and audit across all frontline health and social care services. The need for residential rehabilitation and detoxification pathways and offers to be readily available and accessible without due delays for those most at risk. the need for effective escalation processes across health and social care, and carer identification and risk assessment and support. What we've done in response to adult L, N and O SARS. A project manager oversaw the SAR and DARDA action plans to take forward actions specifically related to drugs and or alcohol. Some of the action outcomes include refiguration of the residential rehabilitation pathway for treatment services, establish links and processes with local volunteer centre to ensure training is shared with charities and grassroots organisations to take a whole workforce approach to upskilling staff across the city, training specific to drugs, alcohol and safeguarding, updated engagement guidance using a trauma-informed lens with input from those with lived experience, purchase and rollout of the Mental Capacity Act and vulnerable dependent drinkers training across the sector, held a joint event between social care and treatment services, and Level 3 refresher training for social work staff includes a focus on learning from SARS and audits. An overview of key learning from adult PSAR. Engagement. Contact was often not achieved. Support was not consistently taken up. Service continuity. Short-term input with no sustained lead professional. Cumulative risk. Patterns across contacts were hard to see in real time. Fire pathway. Uncertainty about what to do when consent for a safe and well visit was not given. Escalation and mental capacity. Very unwell presentation and fire risks. Limited shared decision making about next steps. And housing involvement. Limited information sharing with housing services. Some changes have already been made in response to adult PSAR. Practice has been reviewed by a focus group and advice taken from the fire service. Additional training has been arranged. A 7-minute briefing on preventing fire deaths has been circulated. The multi-agency form for raising adult safeguarding concerns now asks about fire risks. It is proposed that the format for care needs assessments should also ask about fire risk. The Newcastle Safeguarding Adult Board SAR Committee will oversee an action plan to respond to the recommendations made within the SAR. So what we're doing to check learning has been embedded. Multi-agency audits with themes focusing on domestic abuse, engagement and safeguarding where the individual has needs related to drugs and or alcohol, self-neglect and health needs. The Newcastle Safeguarding Adult Board's Improving Practice Committee have a case presentation at each meeting which reflects some of the reoccurring themes coming from local safeguarding adult reviews. The aim is to demonstrate that good practice is being shared and that learning from reviews is being embedded. Multi-agency safeguarding audits. Multi-agency audits continue to identify areas of good practice across Newcastle, with strong commitment from agencies to keep adults safe. However, they also highlight recurring themes across multiple years. You can find out more about the findings from our most recent multi-agency audits using the following link. So what's working well? Strong multi-agency commitment to safeguarding with evidence of appropriate referrals and proportionate responses. Good partnership working in many cases, particularly where information sharing and coordinated responses are evident. Evidence of person-centred approaches, including consideration of the individual's views and wishes in many cases. Routine consideration of mental capacity in safeguarding processes with examples of appropriate application of the Mental Capacity Act. However, what needs to improve? Carers are not consistently identified or supported. Risk is not always clearly coordinated across agencies. Voice, engagement and advocacy need strengthening. Mental capacity assessment, recording and application is inconsistent, and thresholds and provider assurance need clarity. So where people can access key documents from SARS in the future. All information relating to SARS is available on the Newcastle Safeguarding Adult Board website. Please find the link here. This includes published SAR reports, 7-minute briefings that summarise these reports as a quick read option, SAR policies and procedures, and SAR referral forms. You can also access the National SAR Library for national SAR information.